Hi everyone, and welcome to our weekly podcast brought to you by VJOncology. In this week's episode, we will be covering our highlights in genitourinary cancer from ESMO 2025, which we attended live in Berlin. To begin, we have Andrea Necchi from San Raffaele Hospital and Scientific Institute in Milan, Italy, who goes through primary results of the GDFather-NEO trial, which assessed neoadjuvant nivolumab with or without isogrumab in cisplatin-eligible patients with muscle-invasive bladder cancer.
Yeah, the GDFather-NEO trial was built on the background of the GDFather-01 trial, which was a phase 1 study testing visugramab in combination with nivolumab in patients with advanced solid tumors already pretreated and refractory to immune therapy. Visugramab is a neutralizing antibody against GDF15, and GDF15 emerged as a target that was highly expressed in multiple tumor types, including urothelial cancer. And the phase 1 data that have been published a few months ago on Nature by Ignacio Melero and colleagues showed that in the cohort of urothelial cancer, there was a huge proportion of responses, and responses were maintained as also updated here at the meeting. So GDFather-NEO trial was the first trial in immunotherapy-naive patients combining visugramab with nivolumab in a randomized study with a combination therapy or nivolumab and placebo therapy just before radical cystectomy by providing the 3 courses every 4 weeks of therapy. And then the patient has a treatment had also to decide on as to whether to do with the radical cystectomy or RT-RBT, so bladder sparing approach that was very much response-driven and patient decision-driven, depending on the response. The primary endpoint of the study was the pathological response rate, and then we also put another primary endpoint represented by radiological response. And the results in terms of primary endpoint was pretty good. 32% of the patients in the combination therapy arm achieved the pathological complete response. 66% achieved the pathological downstaging major response to non-muscle invasive disease, as compared to nivolumab and placebo arm. So the results were tripled in terms of pathological complete responses. And also the same, and it was 4-fold higher in terms of radiological responses, when we have seen 60% of radiological partial or complete responses in the combination therapy arm. Most importantly, the combination therapy was pretty well tolerated. There were no grade 4 or 5 adverse events. The time from cycle 1, day 1 to surgery was in line with the protocol allowance. So it's the grade 3 adverse events reported in both arms were pretty well tolerated and in line with what is expected actually with the checkpoint inhibitor. So globally, it's an intriguing combination, visu and nivolumab, and certainly warrant a further investigation in the field that is going complicated, with multiple trials having readout of the data this year at the meeting, but adding additional drug that not add an extra toxicity, it's important for combination therapies in these patients in this curative setting.
He also discusses the SunRISe-4 trial of neoadjuvant sertolizumab with or without TAR-200, a gemcitabine-releasing intravesical system in patients with muscle-invasive bladder cancer.
SunRISe-4 trial was a trial testing the combination of gemcitabine intravesical system, TAR-200, and sertolizumab, or sertolizumab monotherapy for 4 courses every 3 weeks before radical cystectomy in patients with clinical T2, T4, and M0 muscle-invasive bladder cancer who are ineligible for or refuse cisplatin-based chemotherapy. The interim results have been presented last year in our session at ESMO and published a few months ago in Lancet Oncology. And here we presented the primary findings and biomarker results. Primary findings actually confirmed the initial findings. 38% of the patients achieved a pathological complete response with TAR-200 and sertolizumab, as compared to 28%. And the response, major pathological response, was higher than 50%. So quite promising and confirming the initial findings. No new safety signals emerged at the primary analysis. And most importantly, we got the initial data on biomarkers focusing on the UTDNA, urinary tumor DNA, and ctDNA, circulating tumor DNA, that were assessed at baseline and at week 12, post-neoadjuvant therapy, just before cystectomy. First, UTDNA. UTDNA at week 12, so post-treatment, emerged as a strong biomarker predicting the pathological complete response in radical cystectomy. First, the clearance of the ctDNA in patients who had the pre-post comparison of the samples was also associated with pathological complete response. Interestingly, ctDNA, which was confirmed to be clearly associated with relapse-free survival, so survival outcomes, longer-term outcomes, was not associated with the interim endpoint of pathological response. So the results combined, the treatment standpoint of combination therapy and the biomarker standpoint of UTDNA and ctDNA are pretty well manageable because they are putting each one single step towards a potential improvement in the management of these patients regarding treatment and regarding the potential for predicting pathological response with UTDNA and outcome with ctDNA. So the ideal setting, the ideal premise, I think, for the next generation blood-sparing approach.
Next up, we have Sara Coca Membribes from Barts Health NHS Trust in London, who discusses the results of the phase 2 CALYPSO trial of durvalumab alone or in combination with tremelimumab or savolitinib in patients with clear cell renal cell carcinoma.
So the CALYPSO trial was a phase 2 trial. It was in VJF-treated patients. It was in a time where the VJF was the standard of care therapy for first line. We enrolled 139 patients in the clear cell cohort, and we randomized them across the 4 different arms. It was durvalumab plus tremelimumab, durvalumab plus savolitinib, and savolitinib. The savolitinib arm was closed early due to a lack of efficacy. The primary endpoint was confirmed response rates above 50%. So what we presented yesterday was the final analysis, and with a minimum follow-up of 40 months, we showed that the durvalumab plus tremelimumab arm had significantly higher response rates compared to durvalumab alone, with a p-value of 0.026. And then the durvalumab plus savolitinib arm did not do much better than the durvalumab alone. And when we looked at the measurement tumors, we did not find any enrichment. We also presented the final PFS and the final OS with a minimum follow-up of 40 months. We didn't show any clear benefit despite the higher response rates, probably because our population was too small. And then we presented exploratory biomarker analysis. We measure PD-L1 in above 100 of patients. We used tumor cell staining and CPS. And when we looked at the PD-L1 positive population in both approaches, we didn't find any enrichment in response in the durvalumab plus tremelimumab arm or in the other arms. We also measured KIM-1 using the standard procedure, and we measured KIM-1 at baseline and after a median of 12 weeks of therapy. We showed that KIM-1 at baseline was prognostic, and we showed also that among responders, the drop in KIM-1 was highest, was statistically significant, and the biggest reduction was seen in the durvalumab plus tremelimumab arm.
She also provides perspectives and the potential impact of the trial, as well as biomarker advances in clear cell renal cell carcinoma.
The CALYPSO trial was a negative trial, so it's not going to change or not going to impact the standard of care therapies, because also it was done in a period of time where the standard of care first line was different than what we have right now. But it was a necessary trial done back in the day, because we can also learn from the standard, not from the experimental arm, but also from the control arm. It was a good control arm. It was a good trial. It has 4 different arms. And we have durvalumab alone. Our PFS correlated with the CheckMate 25. In CheckMate 25 was 4.5 months. In ours is 6.5 in the durvalumab alone and 7.5 in the durvalumab plus tremelimumab. So our results correlated with this trial, even though we didn't find any significance in the PFS or in the OS. So it's not, I think the biggest point is not the impact in the standard of care, but also what we have learned from it. And what we have in the future ahead, which is really promising, is that we know that PD-L1 hasn't consistently confirmed any enrichment in response. So we need to prospectively validate KIM-1, and we're going to PD-L1, and we're going to prove its role prospectively for the first time in the ongoing CARE1 trial, which is actively enrolling. So we really think PD-L1 will be proved in this trial. And our trial just proved, again, that when we look at PD-L1 retrospectively and as part of an exploratory analysis, we didn't find anything. And KIM-1, because it's very promising, we have shown again that KIM-1 is consistent and it's promising. And we definitely need to pursue the role of KIM-1, and we need to prove its efficacy prospectively.
Following on, Dr. Tagawa from Weill Cornell Medical Center discusses the PSMAddition trial, which evaluated lutetium PSMA-617 with ADT and an androgen receptor pathway inhibitor in patients with PSMA-positive metastatic hormone-sensitive prostate cancer.
The PSMAddition trial, as the name implies, looked to add in PSMA-targeted radionuclide therapy to the standard of care of ADT and ARPI in the setting of metastatic hormone-naive, what some people call hormone-sensitive prostate cancer. Lutetium PSMA-617 has already shown to have a benefit in the later, more pre-treated hormone-resistant patient population, but it makes sense to move it earlier because there's generally less PSMA negativity in the earlier settings, as well as what we believe less likely to have radioresistant changes. So we'd expect more of the targets, more sensitivity to the payload, if you will. And then the backbone treatment of ADT and ARPI may influence in terms of upregulation of the target for PSMA, as well as radiosensitize. So all those factors together led us to do this trial. And what we need is a randomized trial to show us, is there a true benefit from the addition of this type of therapy or not? And so we conducted the trial. The primary endpoint was radiographic progression-free survival. And at the first interim analysis for this efficacy endpoint, there was, by the study definition, a positive result. So a 28% improvement in radiographic progression and or death versus the active control of ADT and ARPI alone. Some of the secondary endpoints were also in favor, at least directionally, of the early lutetium PSMA-617 arm, such as overall survival and some of the PSA endpoints. Adverse events were more common in the lutetium group, although fortunately mostly low-grade in nature. Quality of life, so not fully analysis, but doesn't look to be a major detriment either, despite the higher number of adverse events.
Finally, with Paul Nguyen from Dana-Farber in Boston, who comments on the ENZARAD trial, which evaluated enzalutamide with standard ADT and radiation therapy for high-risk, localized, or locally advanced prostate cancer.
ENZARAD, or ANZUP 1303, was a phase 3 international investigator-initiated randomized trial, and it enrolled from 8 countries, 802 patients with a median follow-up of 8 years. The 8 countries were Australia, New Zealand, we had the UK, Ireland, the rest of the EU, and then also the United States. And basically, the key question in ENZARAD is, can we improve metastasis-free survival by adding 2 years of enzalutamide to patients with high-risk clinically localized or locally advanced prostate cancer receiving high-dose radiation and 2 years of a GnRH agonist? Now, I will say in the control arm, we did give 6 months of a non-steroidal anti-androgen. The primary endpoint was metastasis-free survival, and this was defined based on conventional imaging. We're talking CT, MRI, or bone scan, and this is based on the ICE-CAP definition that was a surrogate for overall survival. We did not include PSMA PET positive findings as a metastasis endpoint. In terms of the power of the study, we had an 80% power to detect a 33% reduction in the hazard of metastasis or death before metastasis. So in terms of the primary endpoint, we did not find a benefit to metastasis-free survival with the addition of enzalutamide. The hazard ratio was 0.88, and it crossed 1. The p-value was 0.34. And at 8 years, the difference was 74% metastasis-free survival in the patients who got enzalutamide and 72% metastasis-free survival in the patients who did not get enzalutamide. There was a difference in PSA progression-free survival. The hazard ratio there was 0.044. The difference was 67% versus 62% at 8 years. And the hazard ratio was 0.78. No difference in overall survival, no difference in prostate cancer mortality. But I do want to say that there's a certain success story here in that both arms did really well from a prostate cancer specific survival perspective. It was 97% at 8 years in the enzalutamide group, 96% at 8 years in the nonsteroidal anti-androgen group, saying that really patients with high-risk prostate cancer these days getting treated with high-dose radiation and 2 years of regular GnRH agonists are doing really well in terms of their outcomes. Now, there were two very important subgroups. So we had pre-specified 5 subgroups and pre-stratified by them, but 2 of them that I want to call out that were positive. So one of them is whether or not you were clinically node positive. For the clinically node positive patients by CT or MRI, there was a statistically significant interaction, p-value of 0.04, such that those who were node positive had a significant benefit to MFS from enzalutamide. The hazard ratio there was 0.43, and it did not cross 1. Whereas for patients who were clinically node negative, there was no benefit for enzalutamide. The hazard ratio was about 0.95. The other subgroup that was significant was those who were selected for pelvic lymph node radiation. Remember, actually, I didn't mention this, but pelvic lymph node radiation was optional in our trial. And so if you were clinically node negative, so investigators could declare. But if you were clinically node positive, which was 11% of our trial, you had to get pelvic lymph node radiation. So of the patients who got pelvic lymph node radiation, there was a significant benefit to enzalutamide. The MFS hazard ratio was 0.47. For those who did not get pelvic lymph node radiation, the hazard ratio was 1.25. And so, how do we put this together? We think that for most patients with high-risk localized prostate cancer in the modern era, getting high-dose radiation and 2 years of hormone therapy, most patients don't need enzalutamide. But for those 2 subgroups of patients, for patients who are clinically node positive, and for those patients who have another indication for pelvic lymph node radiation, I think that there is some good evidence from ENZARAD to add enzalutamide. So that's kind of the summary, but happy to discuss some more.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this podcast, please leave a review and subscribe on your favorite podcast app, including Apple, Podbean, and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology and join in the conversation, and visit VJOncology.com for the latest updates in the field.